Well, good afternoon, ladies and gentlemen, from a warm, wet and windy Cape Town. It's a great, great occasion, and this is the last before the holidays. You'll remember that next week is Youth Day, and for that reason, we will be suspending our webinars until the middle of July. But we go out with a bang in this season, episode 18. We have Dr. Lo Pistorius of Mediclinic Panorama Fetal Assessment Center. He is the professor and head, but he prefers not to be introduced as the professor and head because he actually works for a living, so he's not a professor. We have also Karen, thank you, Karen, who's now joining us, and Ash. I'd like to see Ash. Are you two people going to be showing your faces, or does load shedding hair take precedence? I suppose the load shedding hair takes precedence. So, ladies and gentlemen,
no load shedding.
There we go. We have Steve Jeffrey, professor and head of urogynecology. He's just logged on, and he will also be joining us as soon as he gets his technology together. The sponsor of this afternoon is MediChallenge. And MediChallenge, we'd like to thank, I will say a formal thank you at the end on behalf of the Pelvic Floor Foundation of South Africa on behalf to MediChallenge. Our presentation this afternoon is Lo Pistorius, and he's going to be speaking about progesterone's the last word. Did we have Steve Jeffrey on over there?
What was it? I cut him off.
You cut him off. That's good. He was just talking too much. He always does. So, ladies and gentlemen, remember, next week there is no presentation because it's a public holiday, Youth Day, and for that reason, most of us youthful people will be on holiday. So, without further ado, without further waste of time, we have Dr. Lo Pistorius of the Mediclinic Panorama Fetal Assessment Center, and I could think of nobody better than to address us on the topic of progesterone's the last word in the management of preterm labor. So hang on there, we've got Steve. Steve, thank you. Can you share your slides with us, please, Lo?
Yeah, hi, Pete, and trust you have made a good recovery, Pete. Sorry, I took a while to join.
Yes, Steve, indeed. Thank you. Last week, I was in fact under the knife. I had a necrotic, septic, necrotic gangrenous gallbladder, but it's amazing how you don't actually need a gallbladder because here I am without a gallbladder, I'm still fine. So, Lo Pistorius, the role of progesterones in women for spontaneous preterm birth, the final word, and we're looking forward to your final word this afternoon.
Right. Thanks, Pete, for the introduction and Stephen. And I think firstly, my disclaimer. I think first I have to mention that the Nitsane gang took me for dinner sometime many years ago. So I think it's time to get another dinner going so that I can have a more up-to-date disclaimer about that. I think my second disclaimer is really that the last word is never going to be spoken, and I think no man can ever make the claim that he will be able to give the last word on everything, let alone the last word on something like progesterone. And I remember when I was registrar, whenever you wanted to start discussion going and be sure that you end up with a good fight, as you talk about cerclage. And I think progesterone has really taken over from there. Now,
Lo, would you mind if we interrupt you? Lo, sorry,
yes,
would you mind
please.
if we interrupt you? We have a very large number of people logged on, and I wasn't sure Steve was going to be with us. So for that reason, I've got reinforcements with Dr. Elmarie Besson. Many of you will be familiar with her face. Elmarie Besson is she always has to have the last word, always. So I am going to have the last word under these circumstances. She's a very busy practitioner and an expert obstetrician, and she's going to be asking you some questions. Thank you, Lo.
Thanks, and it's indeed very nice to have Elmarie on. She always joins remotely, but indeed nice to have her on with Pete this morning or this afternoon.
This evening.
Right.
This evening, yeah, it still feels like morning.
Great, yes.
Anyway, yes.
Great, thanks, yeah. So please interrupt if there are questions. I'll watch the Q&A as well, but please feel free just to interrupt me, and if I carry on, you know, just mute me. That's fine, that you can get your word in. So again, no need to remind you why we're worried about premature. I mean, worldwide, it's a huge cause of morbidity and mortality. In our own beloved country, it's no different. 10% of babies end up ending up being born too early. And if you look at the neonatal deaths, next to intrapartum related events, complications of preterm birth form about a third of all causes of neonatal deaths. And, you know, really for a long time, we'd be hoping that we can have a kind of obstetrical success story. And, you know, we all love happy endings. And we were really hoping that by this stage, we could have a much bigger success story about prevention of preterm labor. And we would really hope that we can have a similar kind of story as with preeclampsia, and just fix this receiver operating curve on your mind. And this shows using the IFMF Foundation algorithm to screen for preeclampsia, what the ROC curve is. In other words, for a very, very low false positive or screen positive rate, we can detect almost all very early preeclamptics at a stage when it still is possible to really prevent 80% of early preeclampsia by doing something as simple as giving the high-risk mom aspirin. Now, the question is really, is progesterone now the aspirin of preterm labor? In other words, preeclampsia should really, early preeclampsia should really disappear. Those tiny little babies born too early from preeclampsia should really soon be really an exceptional event in the neonatal ICU. And can we make the same claim with progesterone? So I think firstly, it's good just to stop and think that progesterone is preterm labor is a syndrome that has many causes. And of course, if it's something that's a very complex syndrome, to think that with a single drug we're going to prevent it, you know, we are really fooling ourselves. And I think our first question really is if we want to use progesterone, and does it work? And it's really was a very interesting history over the last 15 years or so, since the group of Nicolaides brought out a big randomized controlled trial on the use of progesterone to prevent preterm birth in women with a short cervix. And very soon there was a meta-analysis, and then there was another meta-analysis. And there was a stage, and at the moment, I think it's still true that progesterone for prevention of preterm birth is the one condition where there are more meta-analyses than randomized controlled trials. So, and
what does that tell you, though?
yeah, so I think what that tells me is it doesn't work as well as we really hope.
Yeah.
But and of course, I think in everything there's politics. You know, we were talking about professional politics before we went online, and the Optimum study, they tried to show that, you know, this really is a lot of nonsense. It's not working. But if you look carefully at your odds ratios, although it wasn't significant, it followed the same trend as Romero's meta-analysis. So, of course, then you get more and more meta-analysis and individual patient meta-analysis and so on. And what we have so far, the last word from last year is really, if we look at vaginal micronized progesterone for at-risk women, and just to take note that this is vaginal progesterone, it's typically the dosage of 200 milligrams at night. And it's not the intramuscular one. It's not given orally. There's really a very high certainty of a reduction in preterm birth before 34 weeks. And basically in the at-risk women, it halves the risk. And of course, it means that still 50% of preterm labor in these at-risk women to whom we give progesterone are still going to deliver early. And there's also, we can be reasonably certain that it actually prevents perinatal death. If we look at the odds ratios there, it looks as though it reduces perinatal death by about a third. It might be as little as 3%, might be by more than half. So we know progesterone does work. And again, vaginal micronized progesterone for at-risk women does work. And now, of course, the question is, who are at risk of preterm labor? And as I said earlier, we actually don't know what the cause is, or there are a myriad of causes. But fortunately, as obstetricians, we don't need to know how something works and what causes it to manage it. Fortunately, we are not physicians that we need to understand it all. And the final common pathway of whatever causes preterm labor is that the cervix will start effacing or shortening. And conversely, measuring the cervical length is useful in predicting which asymptomatic women might go into labor too early and deliver too early on. And we've known for decades now that there's an inverse relationship between the cervical length and the gestational age at labor. In other words, the longer the cervix, the later it will take until the patient goes into labor. And it's not as easy that the cervix is 40 millimeters, the woman will deliver at 40 weeks, and if it's 24 millimeters, she'll deliver at 24 weeks. Would have been nice if it were like that. And secondly, although this isn't primarily what this talk hinging on progesterone is about, we know that measuring the cervical length is really useful in the management of symptomatic women. Now,
hello, can
yes.
I just interrupt?
Yes,
we had
please do.
We had a talk the other day. When we get a report from your fetal assessment center, you always give us the cervical length. Is it worthwhile measuring cervical length on everybody or just those at risk?
Right. If you don't mind, I'll park your question because I'll come around to that in a couple of slides from now.
Yeah.
And but I think that really is a very pertinent question, and I think as society we should be answering that question for ourselves.
Okay.
So question is, if we know a short cervix puts a woman at risk for preterm labor, when is a woman's cervix short? And we can go by centiles, or we can go by the predictive value of a specific cutoff point, or we can do the Kipros type of thing and look at the relative rather than an absolute risk. And it's also, it probably depends on the population in which we work, and also the time at which we measure the cervix, because if we measure the cervix before 18 weeks, we tend to overestimate the length of the cervix. And if we measure it much after 24 weeks, then we've actually missed the boat, because the patient might already be in labor by the time we try and institute some prevention. So of course, it's all relative, and it depends a bit on what the background risk is of the particular patient's risk of preterm labor, but also the population in which you work. Is it 5% or 15% of patients delivered too early? But by and large, sort of in collective wisdom, the international guidelines would tend to tell us that 25 millimeters is a useful cutoff point, because then you will end up with a 4% of patients that are screen positive. In other words, we already scare 1 in 20 women who come to our clinic by telling them they've got a high risk of chromosomal abnormalities. Now we hear another 1 in 25 women by telling them they're at risk of preterm labor, but at least it's only a 4% screen positive. And on the other hand, it has a 35% sensitivity. So it's also good to realize that if we go by measuring the cervix to prevent preterm labor, at best we can only hope to institute a prevention in a third of women who are going to, who would have gone on to deliver too early. And then, of course, the same as the story with preeclampsia screening, where we look at the uterine arteries, there's a question, should you look at notching or not? And should you look in the cervix, should you look at funneling? Is it a normal closed T-shaped cervix, or is there Y or V or U-shaped funneling? Is there sludge or not? You know, and you hear the talks at the congresses where people really get really excited about sludge and its value. And, you know, they put the needle in there to have a look at what is in the sludge. Should we look at amniotic separation? But none of these on their own contribute significantly. So, you know, it's worthwhile noting if it's there, you know, just to know for yourself that you've seen it. But in terms of screening women for preterm labor, it doesn't really contribute any more than just looking at the cervix itself. Now, the other question is it okay to look at the cervix transabdominally, or should we be looking at the cervix transvaginally? And the intervention protocols have, by and large, if not all of them, been based on transvaginal screening. And of course, if we then really want to do that, we need to tell the patients that come to us for a 20-week scan that we're going to do a transvaginal scan to check the cervix as well. And probably most patients wouldn't be bothered too much about that. Another school of thought, and there's been a relatively big Danish study on it, is whether we can't look transabdominally. And if you can see transabdominally, you see the cervix well and it's nice and long and closed, then you know if you're going to measure transvaginally, it's going to be fine. And that's sort of my own approach, is to every woman who hasn't delivered at full term in a previous pregnancy, so that would be either someone who's a primigravida, so she hasn't had a previous pregnancy that we know what she's about, or she's delivered prematurely due to preeclampsia, or she had a miscarriage and a DNC in a previous pregnancy. I'll have a careful look transabdominally. And if I can't see well enough, then it's actually the exceptional patient who would say, you know, when I tell her, you know, I'd like to see the cervix, I don't see it well enough, let's just have a look transvaginally. If you're okay with that, that they actually buy into that. Now, of course, the guidelines talking about screening talk about transvaginal screening. So I think it's good to be aware that if we do transabdominal screening, we are putting ourselves out on a limb, so we need to use a higher cervical length cutoff. And a certain percentage of women are going to end up with a transvaginal scan anyway. And now back to your question, Pete, you know, should we screen everybody or just the women at high risk? And if we look at this kind of diagram of all women that end up delivering too early on, and that's the 10% of pregnant women that deliver too early. And if we look at those with a history of 2 previous preterm deliveries, those with a history of 1 previous delivery, those with a cervix shorter than 15 millimeters, and these particular authors looked at those with a cervix between 15 and 30 millimeters. You can see that if we only start off by screening the women known to be at high risk, we are going to miss the women that would have been asymptomatic with no other specific risk factors, where we might have picked up the short cervix. So this really tells us if we want to make an impact on preterm delivery, we actually need to screen everybody. And the ISWA guidelines on the role of ultrasound in the prediction of spontaneous preterm birth that came out last year, said that when feasible, transvaginal cervical length measurements should be performed at the second trimester scan to screen for preterm birth. And that is now for everybody. Now, of course, this is quite a strong statement, and I qualified it to say that there has to be the expertise available, the skills available, the right equipment available, and of course, the follow-up in case you find a short cervix, that you don't tell the patient, sorry, my lady, your cervix is short, but there's nothing we can do about it. And this also doesn't make a lot of sense in screening. And I think this is something that I think as gynecologists, we should look at whether this isn't where we should be going. Now, I'm not going to talk too much on how to measure the cervix, but I feel I have to say a little bit about it because, if you are listening to me and you decide tomorrow I'm going to start looking at the cervix, there's as with everything that we measure in ultrasound view, there's a huge inter-observer variability. And there are two groups who have tried to reduce the inter-observer variability. And the first is, of course, the Fetal Medicine Foundation. And you can log onto their site and go through a little talk on how to measure the cervix. Send them 2 pictures, I think one of which is should be a cervix less than 20 millimeters. And they will accredit you, and once a year just ask you to send along a picture of the cervix again. And then you know that you might be measuring differently to Roberto Romero or whoever was the third author of the Optimum study, but at least you're measuring the same as the patients that were included in all the FMF protocols were measured. There's also a group in Oklahoma. I was actually thinking, why not Texas, but in Oklahoma called CLEAR. It stands for Cervical Length Education and Review. So if you don't like Kipros, you can log in onto the CLEAR website or get the CLEAR app, and they can also then tell you this is how you should be measuring the cervix and you are doing it correctly. So practically, a couple of things that's really important to know is that the mom should have an empty bladder, because if her bladder is too full, the bladder can press on the cervix and make it look longer. The second thing is not to press too hard on the cervix, and the way in which you would know that is that the front and the back of the cervix are equally thick, because if you press too hard, you actually indent the anterior lip of the cervix. And by pressing too hard, you can actually also include a little bit of lower segment into the cervix and give a false long reading. As with everything that we look at, magnified so that the cervix really fills your whole screen. And then basically 3 minutes, 3 measurements, 3 minutes apart. And I mean, there's only thing longer than this, I think, is doing a Lord's procedure. That I don't know how long that takes, but 3 minutes doing transvaginal scanning, just looking at the cervix, really takes an age. But once you've done this for a while, you will see that it's sometimes you see a very, where are my hands now? Very nice closed cervix. And as you just sit watching, you can see the cervix opening from inside as there a contraction and then closing again. And of course, the predictive one is the shortest measurement. So the cervix opens and closes again. That shortest measurement is the one that counts. So, to make the 3 minutes go by, I, just usually have a look at whatever else is around. You can, of course, measure the uterine arteries transvaginally as well. So if you want to say measure the cervix and then left and then right uterine, or look at the cervix and, if the baby lies head down, you can have a nice look at the baby's brain. If it's lying bottom down, you can get really clear pictures of the genitalia for the granny or for the real party, or you can have a nice look at the lower end of the spine, which you might not have seen if the baby's sitting with the bottom deep into the pelvis. But make those minutes go by while you're watching the cervix, and just come back to the cervix every now and again just to make sure it still is long and closed. Right. So,
Lo, if I can just quickly get rid of the questions. Leon Nell, who's from Port Alfred, he says, could you please advise me on how to attend accredited ultrasound training? I want to improve my skills. Can I talk to you guys? And I think that is a good way to improve by means of the Fetal Medicine Foundation. Would you say that? Fetal Medicine Foundation is a good way of improving your skills?
Yes, absolutely. And we will be running one of our 3-day ultrasound workshops at sort of first, second, third trimester. And what we will do is to include cervical length in there. And we do plan to have an accreditation day for first trimester, nuchal translucency, etc. scanning a bit later in the day, probably end of August, end of October, so that we don't interfere with the Pretoria update. But,
okay, so it's fantastic. He can get hold of you. And anybody that wants this talk, of course, can get via Ash and Karen. They can get these talks. One last little question over here. It's a difficult question. I don't know if you can answer it. It's how long is a piece of string? In other words, what is the average cervical length in women? I don't know if there's an average. Do you have a number, or is it depending on the trimester?
Yeah, so and again, it changes a bit in trimesters, and Kathy Kluwer is the theory which I tend to agree with, is that it probably depends on the woman's height as well.
Oh, wow.
The Dutch women are the tallest on earth. I think short, maybe the Norwegians. And there was a study looking again at progesterone to prevent preterm labor, which was nearly thrown out of the journals because the cervical lengths they measured were quite a bit longer than the average. So,
okay, so that depends is the answer. And
so
are the women with naturally short cervixes, can they go to term without intervention? But you're going to be talking about that now, so let's come back to that.
Yes.
Thanks,
No, absolutely. So that last one is, of course, I mean, it's none of these are absolute. So it's still a screening test. So there is going to be that screen false positive as well.
Okay.
And I think in Kipros's cervical study where they randomized to progesterone or not, or it might have been Saclage or not, I can't remember which. There was the patient ending up in the placebo. I suppose it must have been progesterone because it's difficult to do a placebo Saclage. But where a woman, I think she had a cervical length of less than 10 millimeters at 20 weeks, ended up in a placebo arm and went on to deliver at 40 weeks. So it still is possible, but we know that, and again, it's because of that, it's a relative risk. It's not an absolute risk. Right. So again, if we look at prevention of preterm labor, if we look at the vaginal micronized progesterone, high certainty of the reduction before 34 weeks, and probably we're going to reduce the number of neonatal deaths as well. And so in other words, the recommendation is 200 milligrams of micronized progesterone every night for asymptomatic women. And this is a group with no prior spontaneous preterm birth. We've just done a scan, found a short cervix, less than 25 millimeters before 24 weeks. And the progesterone then carries on from the detection of the short cervix until 36 weeks. Now, what else can we do? And we all tell the women, stay in bed, and that doesn't help. It might actually increase the risk of preterm labor. We tell them to stop exercising, and that's also not helpful. In fact, there's been a study where they randomized women between reducing exercise and not. And the ones that carried on with moderate exercise, and I mean, that's not trail running and boot camp, you know, it's walking around the block for half an hour 3 times a week. The group exercising actually had a lower risk of preterm delivery. So putting the moms into bed or stopping their exercise. And again, you know, there is some common sense, you know, if she really pumps 50 kilograms of weight 3 times a day, you know, that might not be a good idea. But moderate, gentle exercise, if the mom does that, she can carry on. So that doesn't help. Cerclage definitely makes a difference if the cervix really shortens to less than 10 millimeters. And again, this is now the asymptomatic group. So the mom, she's a primigravida, she walks in, she has a scan, and lo and behold, she has a cervix of 22 millimeters. She starts the progesterone. So it still is worthwhile monitoring her cervix. And if her cervix shortens further, if it's less than 10 millimeters, there is definitely an added benefit to doing a cerclage as well. And
hello, can I just ask, just on the
yes.
subject of exercise and bed rest, what about intimacy? Because of the prostaglandin
Yes.
angle, should they stop that, or does it really not matter?
Yeah, so there, the evidence is also pretty thin, but I must admit the majority of guidelines would say where the cervix is short enough that you would start progesterone, that is probably better to stop sexual intercourse. And again, it might be over caution, but you know, I think, as you say, there's a good biological reason rather to refrain. The other thing you might read about is the Arabin pessary. And so far that's been tried, and as often is the case, the initial studies looked really, really promising. And once the bigger studies and meta analyses came out, it doesn't look as though it really makes a difference.
What is Arabin?
So that's a pessary that basically fits around the cervix. So it's a kind of a pessary that does the same job as a cerclage would have done, if you can. And so it was developed specifically to keep the cervix closed. But I mean, it's a nice idea, but it to be honest, it smells horrible, and it doesn't seem to work. So at this stage, you know, if you know, it's really only should be used inside research protocols. So if someone starts selling those, you know, show them the door and invite Anita in. Sorry.
Just another question, just to knock this on its head. People seem to have got fixated about sex suddenly. They say, is sex okay with a condom? Shall we just say no sex, no condoms, just no?
That's right.
Condoms, nothing,
yes,
no sex.
That's right.
Just say no.
No sex. Yeah, no sex. We do as if we're British, so no sex.
No sex, please. Be British. Yeah.
That's right. Right. Other risk factors, and the obvious one, and I think that you alluded to about who should be screened. Previous preterm delivery, basically everyone should have progesterone. And there, it is possible that a subgroup of women with a previous preterm delivery that has a completely normal length cervix, the progesterone might have less of an effect. And so the question is, should you be screening by cervical length and only then putting the moms on progesterone where the cervix shortens? And the problem with that is the same with someone, to my mind, where there's a historical reason to put in a cerclage. If you sit waiting, you might very well miss the bus, that you get past the point where you actually should have been doing something. On the other hand, it still is worthwhile monitoring these moms. So she's had 1 or 2 previous preterm deliveries. She is on progesterone, and now the cervix shortens, and that is also a subgroup where it might be worthwhile doing a cerclage as well. Then, of course, talking about cervical incompetence is, setting yourself up for difficult questions, but basically just sort of the current state of thinking about is that cervical incompetence is actually maybe a misnomer, because it actually implies a separate condition, which there isn't, and it probably is just the worst part of the spectrum of a cervix that doesn't do its job quite well. But if you look at it from the point of view is, if we put on this label and say this is the patient that should probably benefit from a cerclage, would be the ones that present with an painless advanced cervical dilatation, or she's had an early second trimester pregnancy loss. So those are the ones that are likely to benefit from a cerclage at 12 to 14 weeks. And I don't know why. I remember as a student, we used to advocate 16 weeks. And now, of course, at 12 weeks, you can make sure there's not an anencephaly or something else horrible for which you wouldn't want to put in a cerclage and then do a cerclage. And for this group, a definite decrease in preterm birth, but it's kind of a moderate decrease. We probably decrease it by about 20%. But we do see we're not so much interested in the whether she goes to 34 or 38 weeks. We're interested to know whether she goes to 24 or 32 weeks. And again, what type of cerclage, McDonald's or Sherrodcar, monofilament, polyfilament, no good evidence one way or the other. I like a Sherrodcar. I think for a couple of reasons. One, not everyone does it. So, I also like to drive a car that not everybody drives.
What caused that, Lo?
We'll talk about that later.
Oh, can I just ask you, are you going to say something about laparoscopic Sherrodcars as well?
I might as well say it now, and basically my other reason for doing a Sherrodcar is in the patients where we need to do an emergency cerclage. I'm always worried if I do a McDonald that you just put the stitch right through the membranes. And of course you can put in a little Foley's and push the membranes up, which we do with a Sherrodcar anyway. But just looking at the length of cervix that you obtain with a Sherrodcar, for me, is definitely better than that with a McDonald. But again, there's no good evidence. So if you know how to do a McDonald's and do it well, that's perfectly fine. The laparoscopic cerclage, and that would usually be an interim cerclage in between pregnancies, that basically looks as though it's places where someone has had a history indicated cerclage that's failed. In other words, she's had the cerclage at 12 to 14 weeks, and despite that, gone on to deliver at 20, 22 weeks. It's I think a little bit more in the gray area. Someone's had an emergency cerclage that failed. So she's gone to 22 weeks, presented with cervical dilatation, had an emergency cerclage that failed. If it's someone that really would rather go the laparoscopic route, I don't think there's something wrong with that. I think on the other hand, I'd also feel comfortable to put in an elective cerclage 12 to 14 weeks while there's still a bit of cervix to work with. And I think we are fortunate that there are a couple of guys around that really do these laparoscopic cerclages with good effect. Does that answer your question, or more questions on the laparoscopic cerclage?
It certainly does. We, as you say, we are privileged that we have excellent guys, and I'm just going to mention one name because it's his birthday today. Suleiman Halen is now 60. Well done, Suleiman. Today he's 60. He's our go-to guy for laparoscopic. Even during pregnancy, he does them. So he's that good. So happy birthday, Suleiman. So it is a wonderful option if you are privileged enough to have that option. Thank you.
Yeah. Happy birthday. Right. Good. So just still on the topic of other risk factors, someone with a previous preterm labor, and we said all of them should get progesterone, but now it's some of the previous preterm delivery and the short cervix. And there it seems whether you give a progesterone or put in a cerclage, there's a similar kind of effect. So if it is a patient that might struggle getting hold of the progesterone or so, or you know she's not going to take it or whatever, then the cerclage would have the same effect. Maybe just back on your topic, I actually forgot about it, but on the topic of cerclage and sex, is the original cerclage was the Shirotka was done with stainless steel wire. So I just tell the dads as well, you know, that originally this was done with stainless steel wire. So you know, just bear in mind this is might very well be what I've used, and I think that tends to put him off. Someone of the previous leads, and you know, basically management would be similar to someone that hasn't had the leads. The only difference is that the cervical changes happen more quickly in someone that's had the leads, it seems. So this might be someone where it might actually be worthwhile just checking with cervix, not only around about 20 weeks, but maybe also 16 and 24 weeks. And then the other things, multifibroid uterus, congenital abnormal uteruses, the patients with Ehlers-Danlos, and those are also like the patients that have the leads. Basically, they need the cervixes monitored. To give everyone with a multifibroid uterus progesterone is unlikely to be of benefit. Same with the ones with the uterine anomaly. And the problem is, of course, if the cervix shortens, you know, it's probably not going to respond that well to progesterone as the woman with a normal uterus. Multiple pregnancy is always a nice topic. You know, should we give progesterone or not? And the evidence isn't as strong. And here again, we have to rely on an individual patient meta-analysis. And if you look at the odds ratios, it's pretty similar to that of the odds ratios for singletons. But you can see the 95% confidence intervals are wider. And then for the twins, you actually have to look at whether you think that for twins and neonatal death, you have to figure out, do you think the risk of one twin dying neonatally is related to that or the other twin dying neonatally? And I think common sense would say yes, because, I mean, by and large, they would be born pretty much the same time unless you really do an interval twin delivery. So neonatal death not significant if you consider them to be non-independent, but the direction pretty much the same. So although the evidence isn't that strong, it still points to the fact that someone with twins with a short cervix would benefit from progesterone. And I think also good to say that it's very definitely true that the twins, just to give a mom, because she is carrying twins or triplets or quadruplets or quintuplets or whatever, to give her progesterone, is very, it's not that there's no evidence of an effect, there's actually evidence of no effect. In other words, you're wasting your time and money by putting all of them on progesterone. But definitely with a short cervix, it is worthwhile. Right, so in summary, prevention for preterm labor in the asymptomatic patient, and this is now taken from the ISWA guidelines. So basically I say single measurement of cervical length, transvaginal ultrasound, cervix longer than 25 millimeters, just carry on, you know, and talk about all the things that you do and measure blood pressure, etc. Short, give progesterone up until 26 weeks. Measure the cervix every week or two up until 24 weeks, because, and I think it's also good to stop because, you know, and I mean, we all have seen these patients that they've become so used to having their cervixes measured, you know, they later 36 weeks and they still want a cervical length measurement. And I think, give the people what they want within bounds, but there's really, it doesn't make sense measuring it after 24 weeks, because the only reason you're measuring is if the cervix is now shorter than 10 millimeters, you'll book her for cerclage. And if she's 26 weeks now with a short cervix, you're not going to do a cerclage anymore. And so that's the asymptomatic moms. And this is now the patient with a previous preterm birth. And the ones that had the really early deliveries, the ones where you think of in terms of cervical incompetence, start a cervical length measurement earlier on. And here you can actually get to the point where the cervix is really short, putting in a cervical cerclage. And this is then a group where you're not quite certain is the history all that strong of a cervical incompetence. And the important thing is to start early enough to look at the cervix. And I think also important, if you look at the cervix at 14 weeks, it's very easy to be misled that there's a little bit of the lower segment that looks as though it's part of the cervix. So really make sure that the part that you measure is just cervix, that it's got the cervical mucosa. And the others, we'll start the progesterone from 16 weeks and then do the measurements. And if it's really short, then consider this cerclage. Now, I've really just talked about cervical length measurements, and the question is, should we look at one of the multifactorial models? And it's a bit like trying to prescribe aspirin for preeclampsia risk just by measuring the uterine artery Dopplers, and we know it doesn't work. Now, if you look at the FMF screening, and you've seen that beautiful ROC curve that I think every researcher would die for, the algorithm for preterm birth doesn't work that well. And if you incorporate maternal factors, and that would include preterm delivery, add in the cervical length, then for a 10% screen positive, and that's now 2.5 times what you would have by using only a 25 millimeter cutoff point, you can see the sensitivity is quite good for the really early preterm birth. So maybe from that point it's worthwhile, but the ones overall, it's not that much better than just looking at the cervical length. There's also a Quip app, which you can download, and this works from 18 to 27 weeks, but it only works in high-risk women. In other words, those with a previous preterm delivery or late miscarriage or previous cervical surgery. And again, you can see it's not a bad ROC curve, but you don't get to that high sensitivities with high specificities. Now, maybe a couple of words of progesterone in symptomatic preterm labor. In other words, you get called to labor where this mom is now 28 weeks and she presented with contractions. And here the cervix is really, the first thing is you're going to do a digital examination, and if she's dilated, she's in preterm labor. If she's not dilated, then it makes sense wheeling in the scanner and having a look on transvaginal scan. And if the cervix is really short, less than 20 millimeters, or some would say 25, then she's much more likely to go into labor. So you're still going to do the whole thing of tocolysis, steroids, and so on. If it's longer than 30 millimeters, then she's not in preterm labor. Whatever gives her the pains, it's not preterm labor. And if it's in between, then you can consider doing those tests for fetal fibronectin or whatever else, is the flavor of the month. And I think practically, if that's not available, many of these patients would end up in the active management arm. Now, maybe just a question, where's the progesterone in here? And the answer is easy. There is no flippant progesterone here, and I won't tell my Alzheimer's joke and get hate mail, but, just looking at this diagram, there is no progesterone. So not to say there is no place, but I mean, at best, it's probably a kind of logical placebo. And my suspicion is these women that present with contractions or whatever looks like contractions, that we have to feel we do something, otherwise they go to our colleague down the road. So we give them progesterone, but that's a kind of a logical placebo. And maybe the Nitsana team should bring us some nice progesterone placebos. And I think it's also just good to remember, as Gerard Visser said, although I mean that was about steroids, not about progesterone, that every medication we give is really poison. We're just using the correct dosage for it. So it's not that, if it doesn't harm, if it doesn't do any good, it's not going to harm. I think it's good just to think carefully before we prescribe anything. But basically, not a big role of progesterone in symptomatic preterm labor. So if I want to get to my final words, if not the final words, so for asymptomatic prevention, progesterone is really, whether the mom's had a previous preterm delivery or she's at risk because of a short cervix, it's really effective. And there's strong evidence to really consider universal screening for preterm labor. And I think one thing that's switched my mind about this was a patient I saw at 12 weeks, beautifully low risk, normal duct, beautiful tricuspid flow, all the pictures I could send to Kipros to renew my accreditation. And then she delivered it at 22 weeks with preterm labor. Is, there is definitely, globally, we know we're going to miss 2/3 of preterm labor, but it's the old starfish on the shore story. The ones that we do pick up, we can really make a very positive difference. And in symptomatic preterm labor, progesterone probably not more than a bit of a placebo effect. And that's really my final word. And just a reminder that, death is also always waiting for us, whether we're in utero, and, we can do what we can to keep death from grabbing a couple of neonates. Thank you.
Hello, that's a wonderful, wonderful talk. I'm going to ask Steve Jeffrey to thank you formally in a few minutes' time, and then I'm going to read out the thank you from MediChallenge. Just to nip through very quickly some of the questions so we can try to get as many as possible. Fidelius, what is the disadvantage of going straight for cyclage rather than commencing with progesterone first? Can you answer that in 20 seconds?
Right. So if we talk previous preterm delivery, short cervix, cyclage is as good as progesterone. So there you might as well do it. In the ones that haven't had a preterm delivery, where you're going to give progesterone, often you would not need to do a cyclage. So you avoid that surgery with its potential complications.
Okay, thank you. Graham Birdsley, previous preterm, when do we start progesterone? You said 16 weeks, I think.
That's right, yes.
Okay, the next question, we're going to come back to Raylene Naidu's. It's a very long question because it's a clinical case. And then Habib from Kenya says, I've seen colleagues in private practice putting in a cervical cyclage and prescribing progesterone. Do you use both? Would you think it's a good idea? Yes or no?
Yeah, I must admit I often do both. And again, I think it depends on the clinical scenario, because of course we can end up doing both by starting with progesterone and adding a cyclage. And there is probably a group of patients that would indeed benefit from both.
Okay. And then there's a thing from Suleiman Helen that says, thank you for the birthday wishes. Then there's Anonymous that says, good evening, doctor. With regards to a patient who's had previous second trimester miscarriage with an elective cerclage who still undergo some cervical dilatation, is there a role for a second cerclage? Yes or no?
Yeah, so yeah, that's a good question, and I think we've all seen those where the first cerclage fails, where, you know, for whatever reason the knot comes loose or so, and you know, you're getting close to the point of the law of diminishing returns, that the odds of a second cerclage working, the first one hasn't worked, is getting less. But again, if it was, let's say, almost a placebo McDonald's sitting right at the external os, and that's going to drift, you know, I would individualize, but, you know, I wouldn't say it is a complete contraindication.
Okay, thank you. Raylene Naidu, I'm going to ask Raylene Naidu just to contact you directly because it's quite a complex question and it's going to take some minutes to answer. Remember that everybody can get these slides from Ash. So that's you, Raylene. Anonymous says, 3 previous unexplained miscarriages and 1 preterm birth, less than 34 weeks. When do you start progesterone? We said it's 16 weeks. Is that correct?
Right.
Another
Right.
anonymous, is there any role for prophylactic cerclage or progesterone in a patient with a short cervix post-LETs? Post-LETs,
Yes,
what would you do? You said...
Yeah, so post-LETs, you measure the cervix, and of course, if the cervix is short, there's a reason to put in a cerclage. So I would say that's an ultrasound indicated cerclage.
Okay, thank you. Now, can I ask Steve to thank you formally, just before I read out the formal thank you
Dr.
from
Young,
our sponsor?
I don't think Dr. Steve is, Professor Steve is on the call anymore. I think it might have dropped off on his side.
Okay, well, in that case,
I have messaged him.
You have messaged him, right. I'm going to read out in that case the formal thank you to Dr. Lo Pistorius from Denise Stryker, who's head of medical marketing of MediChallenge. Good evening on behalf of MediChallenge. I'm reading this with a straight face. I would like to thank Dr. Stephen Jeffrey in his absence, Ms. Ashley Marais, Karen, and the Pelvic Floor Foundation for the opportunity to sponsor an evening of education once again. I would like to say a special thank you to Lo Pistorius for sharing his time and wit with all of us and his eloquence and thought-provoking presentation. And I'd like to second that. It was a beautiful presentation, Lo, and thank God we've got it on tape. I've no doubt that those who attended this webinar benefited greatly. I also have no doubt. Furthermore, MediChallenge would like to pledge its support to the worthy cause of providing CPD via the Pelvic Floor Foundation. Wishing you all a very good evening. Thank you, Denicia. We now have to play out with a 2-minute video, which will take us nicely up to 6. Lo, a great thank you. Elmarie, would you like to say a few words to Lo? You said you wouldn't, but would you like to? Have you changed your mind? Have the last word?
No, I think Lo, hey, Lo, that was a very nice talk. Thank you as always. It's beautiful. Thank you.
You're welcome. Thanks. Nice seeing you as well.
Lo, we had over 200 attendees, and I think that's the record. We very seldom get over 200, and it shows you how important your talk was, and it shows how important and popular you are. So, ladies and gentlemen, Ash, if you could play out you and Karen with our Thank You MediChallenge video. Remember, for the next 6 weeks, there's no more talks. Have a wonderful youth day for all of us, and look forward to seeing you the next episode in 6 weeks' time. Thank you very much, Lo.
Right, you're really welcome. Thanks for having me.
MediChallenge, your trusted partner in women's and men's health. MediChallenge is a wholly owned subsidiary of Bizarre Healthcare, a global company with registration and partnerships in 93 countries worldwide. MediChallenge specializes in women's health products with trusted brands such as Femigel as transdermal 17-beta estradiol, Utrogestin as micronized progesterone in softgel capsules available in 100 and 200 milligrams, and Mifegene as mifepristone 200 milligram tablets. MediChallenge also recently launched the first registered transdermal testosterone, Androgel. Femigel provides relief of symptoms due to natural or surgically induced menopause with invisible percutaneous once-daily gel application that is easy and allows for titration of the required dose. The risk associated with transdermal hormone replacement therapy given in standard therapeutic doses is no greater than that of the baseline population. You can consider transdermal hormone replacement therapy for women who are at an increased risk of venous thromboembolism, including those with a BMI of over 30 kilograms per square meter. When the use of progesterone is necessary, micronized progesterone is considered the safe alternative. For more information on our products, please feel free to contact any of our sales representatives, Yajna, Mandy, Michelle, and Mike, or send an email to denitsa@medichallenge.co.za, or visit our website www.medichallenge.co.za.
Thank you very much indeed. Ladies and gentlemen, safe home, and looking forward to seeing you all in 6 weeks. And thanks again, Lo. Wonderful talk, wonderful presentation.
You're welcome. Thanks a lot. Safe holidays.